Childhood and it is MCH in orthopedics. He specializes in primary and revision knee and hip replacement and minimal invasive spine surgeries. At present, he is, as I said, attached to his own hospital called the VNA Hospital in Shivalik. He is also a visiting consultant to Apollo Spectra Hospital. I think probably one of the more awarded and recognized orthopedic surgeons. He has multiple memberships, a very rich experience, and as I said, an extremely good skill set on orthopedics. Over to Dr. Abhishek Mishra.
Thank you, sir, for your generous words. At the outset, let me congratulate Dr. Almas and Dr. Chauhan for organizing such a wonderful initiative. It's a novel concept. We hardly, being doctors, especially being surgeons, we hardly talk about preventive aspect of medicine, especially in orthopedics. And bringing this back to light is going to go a long way. It's the need of the hour, and it's only going to become more important with each passing day. So I think we are at the fag end of the day, and I'll be very quick with my presentation. I'll just skim through the slides. Again, like when we are talking about preventive orthopedics, basically the best way to treat orthopedic conditions is through preventive care. There is no medical professional more qualified. So orthopedic surgeons, when we talk about preventive orthopedics, orthopedic surgeons, the emphasis is on the word surgeons, are the most qualified persons to talk about preventive orthopedics and to teach preventive orthopedics, because they are the ones who know what is going to happen if some things are not done, or what is going to happen if some things are done. So they know the outcome right at the outset, and that's why orthopedic surgeons are the best persons to talk about preventive orthopedics. What is preventive orthopedics? It's like treatment focused on reducing risk of developing illnesses, diseases and conditions. So when we talk about this, let's just recall the WHO definition of health. WHO definition, probably it has been talked about in the course of the day sometime earlier. WHO defines health as it's a state of complete mental, physical and social well-being, not just an absence of disease or infirmity. So that is what health is. And to bring good health in all the ways, especially orthopedic health, it deals, or it is concerned with, it focuses on treating issues before they occur or become worse or more serious, and before treating it before it needs surgery. So surgery has its own upsides and downsides. The downsides are the long time of recovery, chances of complication, and of course increased cost to the nation, society and the patient's family. So anything which goes, which helps in preventive surgery should be very useful to the patient and the society at large. A knowledgeable orthopedic surgeon will understand orthopedic conditions and all treatment options thoroughly. So basically what I'm trying to say that these days, even my colleagues and in our fraternity, there is an increased tendency to jump at the surgical treatment straight away. In fact, surgical treatment should be the last treatment option if everything else fails. So we should try to treat most of the things non-surgically, and rather going a step ahead, we should try to prevent these conditions. And when we talk about orthopedic conditions which can be prevented, I would dwell upon three main topics very quickly. Like one is trauma, which can be prevented, especially in elderly. Osteoporosis is the most important thing which can be prevented. And osteoporosis is a very, very, very significant condition. Why? Because it's also called silent epidemic. Talking about osteoporosis, it's a condition in which the bone becomes thin, the mineral content of the bone becomes less. And the good thing about osteoporosis is, it is preventable to a great extent. The bad thing is, osteoporosis usually does not have many symptoms, and the patients do not realize they have osteoporosis until they meet with a fracture, which can be limb-threatening or life-threatening, depending on the extent of injury and mode of injury. So preventive measures includes getting adequate calcium intake, which is like in youth 1300 milligrams a day, and after adulthood like 1000 milligrams a day. That also depends on your dietary intake and your sun exposure and other associated factors. Resistance exercises, walking or jogging can be utilized for strengthening bones. While flexibility exercises, they decrease the risk injury. You are more flexible, the less are the chances of fall and the less are chances of getting a fracture. For women, the physician should be, the women should ask their physician about the medications which are available. Like in the previous talks, we were talking about some selective estrogen receptor modifier and some other medicines. These days there are so many categories of drugs available which prevent severe osteoporosis to the extent that, like in the sense that if you diagnose with mild osteopenia and if you start those medicines, and two medicines I would like to mention here, one is denosumab and the other is teriparatide. These are used very recently, like in the last couple of years, last 5-6 years. Their use has increased multifold and they go a long way in preventing severe osteoporosis resulting in major falls. So basically this is a, when we talk about, these are the 4 factors which prevent osteoporosis. Nutrition, diet should be good, regular exercises which include strength training and resistance exercises, quitting habits like smoking and alcohol. We don't always practice what we preach, but nonetheless it is important. Quitting smoking and alcohol is very important. And consultations, if you are in doubt, consult, get tested. Like Dr. Kalra was talking about DEXA scans. So in post-menopausal women, getting a DEXA scan at a regular interval doesn't hurt. And if you detect osteoporosis or osteopenia, you can treat it very effectively. You can prevent it from becoming worse. And maintaining an adequate supply of vitamin D, this fact cannot be overemphasized. So the easiest way to get vitamin D is like through the medication, like talking about sun exposure, how long and what time. I mean, rather than talking about all this, I generally tell my patients the easiest way is to take supplement yourself. And in the regular protocol, which is like initial 2 months, weekly, and then once a month. And that would also depend on the baseline vitamin D levels. So healthy weight is very important. Now talking about osteoarthritis or degeneration of the joint, it is documented that just a 10-pound increase in weight, it increases the risk of developing osteoarthritis approximately 40%, because more weight is transferred to the joint and the joint gets degenerated or degraded earlier. Movement is very, very important. Sometimes there is a misconception, like patients who have knee pain or who have early osteoarthritis of the knee, they have this idea that they should stop walking, otherwise the knee will get degenerated more. It's completely false. A certain level of activity should be maintained. In fact, I encourage my patients to do stair climbing also, even if they have osteoarthritis, because this is a different kind of exercise. Now, not unnecessary stair climbing, but whenever needed, they can do it. So the idea is the patients to keep their mobility intact, because movement, they keep the muscles healthier and stronger. Developing a strong core is very important, because it's the core muscles which balance the body weight, and yoga and pilates are like good exercises to strengthen the core of the body. We should stretch before exercises, especially if you are planning to do weight training and high intensity aerobics. Stretching is very important. Similarly, warming up is also very important. Comfortable shoes. Now, this is an important fact which is many times ignored. So comfortable shoes are very important because they help in maintaining balance and preventing fall and getting into the shape of things easier, in a more easy way. Regular checkups. Yearly visits to primary care doctor is a very important way to stay on the top of the orthopedic thing. This is especially important for older adults who can be more likely to develop arthritis and they can suffer injuries. A primary care doctor can also discuss additional methods or measures to prevent deterioration or degeneration of the bone. Creating a safe zone at home is very important to prevent fall. A safe home as well as safe workplace. If we are working in computers, we should consider a standing workstation and we should shift from sitting position to standing position if you are supposed to work for longer durations. The typing speed and typing thrust should be soft. It should not be very high, and we should take breaks frequently. Ideally, they say that we should not sit on the system for more than 30 minutes at a stretch. If physical labor is a part of our job, we should be aware of repetitive movements. There is something called RSI. RSI is a known entity. It's called repetitive stress injury. So performing the same set of action again and again puts too much stress on a structure such as ligaments, tendons or bones, and can lead to injury or damage, which can result in pain and other ailments. So prevention in sports medicine, just a bit about sports medicine. This is the basic treatment, like first treatment, basic treatment, everybody knows about this: rest, ice, compression and elevation. The first things to be done if there is a sports injury: rest, ice, compression and elevation. Now in sports medicines, a new, rather newer concept is developing. There is something called prolotherapy. There is something called PRP therapy. So these are proving to be very, very helpful. There is a subset of doctors who especially work on regenerative medicine, and many conditions like early osteoarthritis or tendon injuries like tennis elbow or golfer's elbow. This prolotherapy, in fact, stem cell injections and PRP injections and prolotherapy like growth factor injection and all, they gradually more and more evidence is coming up, which is showing that the chances of the reduction in osteoarthritis is there and chances of progression to severe osteoarthritis is there if we adopt these measures. So basically this is just about prolotherapy, in which mostly dextrose, saline and serapin injection is used, and also many a times to refine it more, different people use growth factors or certain other substances in those injections which make it more efficacious. Physical therapy is a very good option for injuries and conditions not adequately managed with basic lifestyle adjustments and anti-inflammatory medication. If the sports injury is capable of healing without surgical intervention, a sports medicine physical therapist should be certainly taken into loop. And physical therapy is a series of treatments, rehabilitation exercises and flexibility training. In fact, many times it is seen that some chronic conditions like tennis elbow and all, they get better. So if you just catch them at the earliest stage, at their inception, like the patient has just started complaining of mild pain and the patient presents to you, then you can prevent it from getting worse and patient can escape the trauma or like the steroid injections or certain other vigorous, more stronger treatment options like surgery and all. So again about prolotherapy, which is very commonly used in knee. In fact, knee, I would say knee is the commonest joint which is held by prolotherapy and where prolotherapy is being used very commonly. So fall and trauma prevention in the elderly, this is like a very, I've come to the last few slides, but this is very important. Most of us have got elderly people in our family like parents or grandparents, and a minor fall, like if young people, they fall even with high intensity, most likely they are not going to get a very severe fracture. But if an elderly person who is osteoporotic gets a fall, they might fracture their hip or wrist or spine, and which leads to significant morbidity and stress on the patient, the family members and the society at a large, because the cost of treatment is ultimately borne by the society. So these are the basic things which can be done. An annual examination of the elderly, which is very important because the eyesight is weak, chances of falling are much higher. Adequate dietary intake of calcium and vitamin D. Smoking and alcohol intake should be reduced. Up-to-date list of all medication. And for the elderly, because many elderly people, you will see that they have like a long list of medication and they should follow it properly and adequately. Any side effects of any medications, like many medications, especially for spine conditions like pregabalin and it's nortriptyline and similar medication, then they can cause daytime drowsiness and the patient might fall. So making the patient aware about this fact is very, very important while prescribing this medication. So we should make sure that all medications are clearly labeled and stored in well-lit areas. Taking medication on schedule with a glass of water unless otherwise instructed. Exercise programs should be maintained and coordinated with the patient and their relatives. We should, the elderly people should also participate in certain kind of exercise like static cycling, and gardening can improve not only bones but also life quality of these elderly patients. So fall prevention, which is very, very important. So these are the things which help in fall prevention. So maintaining railings, lights at night, making sure that the rugs or carpets do not have folded edges. So just using an anti-skid carpet or putting a sticking tape beneath the carpet and make it stick to the ground. And the area should be well lit, the shoes should be properly fitting. So these things can go a long way. If you prevent a fall, then of course, I mean, you don't have to deal with the problems it brings along when the patient actually gets a fall. So home modifications to prevent falls: furniture should be rearranged. No furniture should block the pathway between the rooms. The clutter should be removed. It's easy to accumulate clutter such as boxes, and the family should take the time to declutter the home, especially the hallway and the stairs. The handrails should be installed on both the sides of the stairs. Ideally, they say it should be 30 inches, but according to Indian conditions, a 20 or 25 inches height of rails in the stairs is sufficient. Night lights should be installed, and the switches of these night lights should be accessible. Suppose if the like elderly person is lying in the bed, the switch should be within the arm's length, so that he can do it while getting up from his lying down position. First he puts on the light and then starts walking and all. These are very basic things which should be kept in mind. A clear path is especially helpful when trying to get to the restroom in the middle of the night. The restroom should be kept dry. This is very, very important, because most of the elderly patients I see who fall in the bathroom, they fall because they slip because the floor is wet. So this has to be given special attention. We should secure all loose area rugs. We can place double-sided carpet tape or slip-resistant backing on all loose rugs around your home. These things might sound to be very trivial, but the consequences it can lead to are immense. And if we take care of these very basic facts, we can prevent falls to a large extent. So proper storage, we should store items that we use on a regular basis within easy reach. For example, clothes and shoes in the bedroom and dishes and cooking equipment in the kitchen. We should install grab bars on the shower wall and along the commode as well, the grab bars, so that while getting up or getting down on the commode, the elderly person should have support. The elderly person should wear the right footwear, wearing properly fitting shoes with non-skid soles, and high heels should be avoided. Shoelaces should be properly tied. We should never walk in stocking feet, and slippers that have stressed out or that become too loose should be replaced, because the people might fumble and fall. We should clean up immediately any liquids, grease or food spilled on the floor. And a play area for the kids should be designated, because children should not clutter the floor with the toys scattered around the house, because there is a risk of getting entangled and again getting a fall. So again, these are very basic measures. I would like to restrict my talk to this point only. So this is a very one quote which I would like to present here. Basically, good health and good sense are two of life's greatest blessings, and good health is mostly common sense in many conditions. Thank you very much. Thanks.
Thank you, Dr. Abhishek, for I think very good talk. And I was just wondering, what will you teach us in the preventive orthopedics? And you came out, I think, with a diamond, I would say. Just a few things. You said that the dose of calcium in people above 20 years of age is 1000 milligram a day. But in practice, we are giving usually only 500. So that is inadequate dose?
That is inadequate. So it should be 1000. But again, it should be titrated with how much, what is the diet like for the patient. So if the patient is having a very good diet, like milk and milk products, and generally the diet is good, then 500 milligrams is sufficient. Otherwise, ideally, like if you are trying to patient with osteopenia or osteoporosis, then 500 milligrams twice a day or 1000 milligrams once a day.
Is the dose for adults same for men and women?
So again, ideally speaking, women should be getting more calcium. And when we talk about this dose, the requirement of calcium is less in males. And but then again, it has to be titrated with DEXA scan especially in elderly. Generally, we don't prescribe calcium to young males. Rather, we don't prescribe calcium to even elderly males. But sometimes, surprisingly, very rarely, you get a DEXA scan in a male who is like 70, 75 years of age, and you see osteopenia or osteoporosis. I told you that like osteoporosis usually does not have any symptoms, but sometimes the patient comes with generalized tiredness or weakness, and in these conditions, and generalized mild bone pains. In these conditions, sometimes the DEXA scan shows osteoporosis even in males, and in those conditions, 1000 milligrams a day should be adequate.
I would also like to ask you, you mentioned about osteopenia, osteoporosis. Is calcium the only thing to be replaced, or we should also think about magnesium?
So calcium, vitamin D, magnesium, other zinc, other elements.
What is the dose of magnesium especially?
So magnesium, there are certain fixed dose combinations which are available. Magnesium is around 10 milligrams along with 1000 milligrams of calcium. But again, now we are talking about osteopenia and osteoporosis. The very important thing is just supplementing calcium and vitamin D is not sufficient. If the patient has documented osteopenia or osteoporosis, then we should fall back on any of these drugs like bisphosphonates or SERMs or denosumabs or teriparatide, depending on the degree of osteopenia or osteoporosis in DEXA scan.
Some of the drugs you mentioned are injectables, like
teriparatide and denosumab also.
So what is the frequency of these injections?
So denosumab is given every 6 months, subcutaneous injection 60 milligrams. Teriparatide is given 20 micrograms subcutaneous every day.
Every day?
Every day.
Every single day of life?
Every single day for 2 to 3 years. So safety profile for 2 to 3 years is known. Generally we don't give it for more than 2-3 years.
How costly is it, sir?
Teriparatide is pretty expensive. The cost varies from like 6,000 to 7,000 a month to 50,000 a month depending on the brand.
And you said it is to be given every day?
Every day the patient takes it himself or herself. Just like it's like a pen, just like the insulin.
So it must be a cartridge?
Yes, it has a pen device.
Pen device and
yes.
it's
and a dial. You can just turn it around and
you take it every day.
Yes.
Right. Now, we also know of certain agents which help with the osteoporotic pains. Some of the female patients who come with, they have severe osteoporotic pains, especially at night. These calcitonin sprays, do they help?
They help, yes. Especially with back pain. Back pain due to osteoporosis.
Right.
But teriparatide actually is the most effective agent which is available right now.
Okay. Any questions? Any questions from the audience?
We should, prevention, there are two things, a good mattress and good posture.
Posture, of course, is very important, and mattress again is important.
Yeah,
yes.
Important
So this when we are talking about back pain. So actually, it's very difficult to define what is a good mattress. But the thing is, it should not be it should not be very soft that you jump and you dip inside it. It should not be like this. It should not be very firm also, because sometimes people have a tendency is सख्त बिस्तर पे सोना है. तो कई बार ना सीधा पलंग पे they sleep on a wooden surface or ground, which is again not correct.
Endorsing some
Dr. Arya has a question.
So before giving teriparatide injection, should one go for IPTH test also?
So you see, when these drugs had come, they were fresh in the market. There were lots of apprehension about their side effects. And even before starting teriparatide, we used to get patients' parathormone levels and so many other tests like calcium. Now generally the only test, I'm talking about the practical scenario right now. Now the only test which we consider before starting is kidney function test, creatinine. Creatinine should not be more than 1.4 or 1.5. If it is more than 1.4 or 1.5, we don't start teriparatide. If the patient has some metabolic disorder, then again we don't start teriparatide. If the patient has a history of cancer, then we don't start teriparatide. Apart from these three things, we can start teriparatide in every other patient without getting parathormone level. Ideally, we should be getting a parathormone level before starting teriparatide, but we are talking about the practical scenario these days.
Sir,
Ma'am?
so I wanted to find out something about arthritis in SLE. So, and how it's different and how it's treated.
Ma'am, sorry, if you talk about the surgical part of it, I can tell you, but
actually,
rheumatologist would be I think the rheumatologist would be a better person to answer this question. I'm not that versed.
Yeah, okay.
why I'm asking this is because there's a patient who had come just recently for a health checkup, had some knee pain, and the knee pain is there. She was operated on. There's a slight bulge in the knee.
So yes, I understand what you're saying. Sorry to interrupt you. So SLE, just like any other connective tissue disorder, it can damage the joints. And in these patients who have rheumatoid arthritis, SLE and other similar conditions, they have a very high tendency to have something called synovitis, which can happen even after knee replacement. And that becomes a constant source of pain in these patients even after undergoing total knee replacement. So this swelling which you might be noticing is indicative of synovitis. You can get an MRI, and if you are getting an MRI in a knee which has already been replaced, you should ask for a specific MRI. It is called Mars MRI, which basically reduces the implant associated signals and makes the MRI more accurate. And if we actually see synovitis in that patient should undergo arthroscopy to clean up the joint.
We need to wind up, Sushil.
Thank you.
Oh, okay. Thank you, Dr. Abhishek. Just stay here. I would request Dr. Jitendra Saxena to felicitate Dr. Abhishek Mishra.